Welcome back to this lesson on clinical reasoning in primary care nursing practice. In the previous video, we explained that clinical signs can have multiple causes, so interpretation must be evidence-based. For example, tachycardia could reflect pain, hypovolemia, hypoxia, infection, or anxiety. Hypotension could reflect from reduced cardiac output, vasodilation, or fluid loss. And altered mental status could reflect to hypoxia, hypoglycemia, sepsis, or reduced brain perfusion. We said that it is good to always use the clinical data provided to justify your most likely causes, not assumptions. We will begin by seeing how we can avoid thinking errors. Even experienced clinicians make reasoning errors, which includes anchoring. They lock on to an early diagnosis despite a new data. Confirmation bias. They also look only for supporting evidence. Availability bias. They even overfavoring recent or memorable diagnoses. Normalization of deviance. They accept abnormal as usual. Please note, a structured frameworks, reflection, and team communication reduce these risks. How do we communicate clinical reasoning clearly? Clinical reasoning must be made visible through communication. Advanced practitioners are expected to explain their thinking during escalation, justify prioritization and decisions, communicate risk clearly to multidisciplinary teams. Please bear this in mind. Clear reasoning improves teamwork, trust, and patient safety. In summary, we talked about errors that clinicians experience, which includes anchoring. This means sticking to an initial diagnosis despite new evidence. Confirmation bias. They focus only on evidence that supports your belief. Availability bias. This means relying on recent or memorable cases. Last among them is normalization of deviance. They accept abnormal findings as normal. We have come to the end of this lesson under Principles of Clinical Reasoning in Advanced Practice. Thanks for watching. See you in the next lesson.